First of all, I'd like David and his team for putting this wonderful meeting together and getting all of you here. And the other thing, I think it's really a wonderful turnout. And it is so important to have the patients here. I think I treat a disease, apart from Castleman disease, it's a disease called multiple myeloma. And I think patient advocacy in that disease has been extremely important. A lot of progress has been made. We have the International Myeloma Foundation, the Multiple Myeloma Research Foundation, and these patient advocacy groups really have made a major difference in the field of multiple myeloma. So it's incredibly important that all of you are here, because all of you are really helped to drive progress that we're making in this disease. So I want to thank you all very much for coming and for your contribution to the field of Castleman disease and trying to develop a solution. So I'm going to be briefly talking about unicentric and multicentric disease, the treatment and the side effects, and address some specific questions. Okay. I think it needs to be higher. Thank you. David always complains that I can't do any slides. It's getting the same. Oh, Dr. Van Rhee, not that many slides. So, when you're diagnosed with Castleman disease, your doctor will do a number of tests. So what are the critical things that we look at? It's very important to get a lymph node out, to look under the microscope, not just stick a needle in and suck a piece out or take a small core biopsy. A big chunk of lymph node, a whole lymph node, is really good. And we want to know that the lymph node looks like Castleman disease. That does not make the diagnosis. The other test you will get is either a CT scan or a PET scan, either will do, to see what the extent of the disease is. Is it one lymph node or are there multiple lymph nodes everywhere? So we can differentiate between unicentric disease and multicentric disease. Incidentally, we like to put people in these boxes. There's unicentric and there's multicentric. There are also people who've got a lymph node here, a lymph node here, or maybe even a lymph node here and a lymph node there. So the distinction is not always black and white. And these people with these very, very limited lymphadenopathy is sometimes called regional Castleman disease. And they really behave more like unicentric disease. So there are people who don't quite fit neatly and tightly in one particular box. Then the other important things are to do blood work. In the blood work, we do molecular testing for the HHV8 virus, and that will help us tell us whether you've got HHV8-associated Castleman's disease. The lymph node itself can be stained for the HHV8 virus as well. It can help to make the diagnosis there. Obviously, the lymph node is important in ruling out other diseases as well. Apart from looking at, ask the patients, do you have symptoms related to these inflammatory symptoms as night sweats, fevers, weight loss, and loss of appetite. We also look for laboratory markers, and I'll talk about the laboratory tests in more detail later. Are you anemic? Do you have an elevated C-reactive protein? What is your kidney function? What is the sedimentation rate? That tells us something about the level of activity of the disease, and also how sick you are. And finally, there are more specialized tests. We call that looking at the cytokines. You've heard a lot about cytokines. What cytokines are floating around? And that sometimes can give us a hint to what therapy may be important. Again, there are patients like David who absolutely have no elevation of interleukin-6 whatsoever. And the IL-6 antibodies are not going to work there. And the other cytokine which is of interest is called something called vascular endothelial growth factor, for which the sirolimus drug may be useful. So the CDCN published the consensus diagnostic criteria for idiopathic multicentric Castleman disease. So how do you reach the diagnosis? Again, you need to have a lymph node which looks like Castleman disease. Doesn't mean you have it. You need to have lymph nodes in multiple places for the multicentric variety. And you need to exclude other diseases that can look like Castleman's disease. And that criteria, the third one here, is very important. And then you need to have some symptoms and laboratory markers which suggest that there's an inflammatory syndrome going on. These are listed here. There's elevated C-reactive protein, anemia, abnormal platelet counts, low blood albumin, abnormal kidney function, and some symptoms which are listed there. Then it's also very important to rule out other diseases, and a whole list of diseases are shown here. The big one is lupus, that most of you heard of. And there's a rare disease called IgG4-related lymphadenopathy, which can cause diagnostic confusion. The other ones are lymphoma, both Hodgkin's disease and Hodgkin's lymphoma. And then there are infections, which can cause confusion and mimic Castleman's disease. So active exclusion of other disorders is very important. So here's the algorithm. So you start with doing the biopsy. The lymph node needs to look consistent with Castleman's disease. Then you determine the extent of the disease. You exclude other disorders. Then you have multicentric Castleman's disease. Then you exclude you exclude or positively confirm the HHV8 associated form. Then there's a form associated with Pompe syndrome. And then you're left with the idiopathic variety. And idiopathic is fancy medical word because we don't know what the heck it's caused by. Doesn't mean that there are no treatments, but obviously we have a long way to go. Unicentric disease, again, it's curative, as David already said, with surgery in over 95% of patients. Some patients, the mass cannot be resected because it's either pressing or invading on something vital, like your windpipe, nerves or large blood vessels, and then other therapies can be considered. This is a young lady from Arkansas, actually, who had this big mass in the chest, which could be surgically removed. This is the windpipe, which should be in the center, and you can see that's moved over. So here's the nice treatment algorithm that we constructed with the physicians and scientists from CDCN. So if you've got unicentric disease, we'll likely try and remove it surgically. If it's not resectable, you can elect to observe it if the patient is asymptomatic. In other words, if it's not causing any trouble. Because the unicentric variety grows very slowly. So there's no rapid enlargement there. However, sometimes it does cause symptoms, either because even the unicentric disease can make cytokines, or it presses on something really important, and that you need to do something about it. You can treat with drugs like rituximab and steroids. Sometimes that will shrink the lymph nodes, and it's a little bit of a hit and miss. You have to try it. In some patients it works, and others it doesn't. If it shrinks enough to make it resectable, you go and do surgery. If it's not resectable, again, you can try to observe. And then there's radiation therapy. Radiation therapy is effective for unicentric Castleman disease in many patients. However, it has a downside. There is a risk of secondary cancers, particularly blood cancers. So sometimes the decision to do that is determined by the age of the person. If you have somebody of 75 who doesn't have an exceedingly long lifespan, the risk of getting a secondary cancer is probably fairly low. On the other hand, you're much more reluctant to radiate a child of, say, 10 years old. So age sort of factors into the decision to do radiation or not. We like to do embolization on unresectable disease. One of the things about these unicentric lymph nodes, they bleed a lot. They're heavily vascularized. So this was a young man from Idaho who went to a big center in Utah. He had this big pelvis mass of lymph nodes in his belly. They opened him up and they tried to remove it, and he bled profusely. And they took a small piece out and they said, well, we can't help you. And he came to our institution, and he had a catheterization, which means they took a catheter in the groin, went up to the lymph node mass, and cut off the blood supply, and they did this on 2 occasions. And here you can see that after, this is all dead tissue here. So instead of this highly vascular, profusely bleeding mass, this mass suddenly became resectable. So embolization can be very useful to make masses resectable. So what do we need to monitor in unicentric disease? Again, recurrence is low. A CT scan initially yearly for 5 years is reasonable. After that, the recurrence rate should be low. If the mass makes interleukin 6 or other cytokines, then blood work might be reasonable. So in general terms, if you think that you got everything out surgically, you're going to be okay with the unicentric disease. Then there's HHV8 positive Castleman's disease. We see a few patients. One of the big centers in the US is at the National Institute of Health. The HHV8 virus hides in cells which are called B lymphocytes, and these cells can be attacked by a drug called rituximab. And rituximab, with or without chemotherapy, is very effective in treating HHV8-associated Castleman's disease. Again, it's a little bit more complicated, the schemas, than what we suggest here. And you really would like to go to a center where they have experience with this particular disease. Okay, turning off to the idiopathic form. So a lot of patients will have flu-like symptoms, night sweats, fevers, weight loss. Others may also have kidney dysfunction. Patients can have low albumin in the blood. Albumin is a major protein in the blood, and it keeps fluid literally in the bloodstream. And if the albumin goes low, it'll leak blood in your tissues. You can get fluid behind the lungs, we call it pleural effusions. You can get fluids in your belly, we call it ascites. And you get swelling of your legs, so we call that edema. And then there are these other laboratory markers, not really symptoms: elevated CRP, anemia, abnormal platelet counts, and increased antibody levels. So the fancy name is hypergammaglobulinemia. So David is quite right. The clinical course is very varied. There are people who have got very mild symptoms. And then there are patients who are extremely ill at the other side of the spectrum. And there are patients who have waxing and waning course, others who have a gradually progressive course. But it should also be said that in general terms, if you have a milder manifestation, you're not going to turn into severe disease. If you have had a big flare, you're at risk of getting again a big flare. So in lymphoma, you have these low-grade lymphomas, and they can suddenly turn into an aggressive lymphoma. Castleman's disease doesn't work like that. If you have a milder variety, you stay with the milder variety. If you have a severe form with big flares and you get very sick, you're definitely at risk of doing that again. So who has severe Castleman's disease? Now, you don't need to be a doctor to see that. These are patients who've been in intensive care. They can have respiratory problems, they may need dialysis, they've got this massive fluid overload. These people are severely ill. And that's about 10 to 20% of patients, is my guess. We established official criteria, which we recently published in this blood paper. So you have a very poor performance status, bad renal function, and then this massive swelling. Usually patients are very anemic and they can have trouble with their lungs. So these patients are quite easy to recognize. Now, how do we treat it? Now, there are a number of different treatments available. Steroids. These are not the steroids which make your muscle strong. To the contrary, they actually cause muscle weakness. Steroids will help. The problem is that you need to give them high dose, and they have side effects. And you can't stay on such high doses of steroids for a longer period of time. Then there are the antibodies which target either interleukin 6 or the interleukin 6 receptor. They're listed here below. There's siltuximab or Sylvant and tocilizumab and Actemra. They're probably both equally effective. The problem with these antibodies is that if you stop them, patients eventually will relapse. Maybe not immediately, but if you take people off therapy, the disease eventually will come back. So in principle, it's lifelong therapy, it's not a cure. So although it's an important, we made important progress by having this FDA-approved antibody siltuximab now available for Castleman's disease, we haven't really solved the problem. Then some patients require chemotherapy. And what I mean by real chemotherapy, that's stuff that can make you nauseated, that can cause diarrhea, and you lose your hair. It's not the easy stuff. But some patients only respond to that. The rituximab antibody has been developed to treat lymphoma. It's been available in the United States since 1998. It's been extensively used for lymphoma. And also to treat autoimmune diseases and other disorders. So a lot of cancer doctors are very familiar with the rituximab drug. They feel very comfortable giving it. And they say, well, siltuximab, Actemra, they start to scratch your head. Well, yeah, I've never given that to anybody. So a lot of oncologists who have not seen a lot of Castleman's disease really like to use the rituximab drug because they're so familiar with it. And the side effect profile is so well known. So these are, this is a treatment algorithm. Now we're going to discuss the first part with you. So if you're diagnosed with multi-center Castleman disease and you're not severely ill, you start by giving an anti-IL-6 drug. The one which has undergone a randomized trial is the siltuximab drug, and that's the preferred drug. In reality, I think both Actemra and siltuximab work equally well, and I don't think that one is better than the other. If you have mild Castleman's disease, it is not unreasonable to try a course of rituximab. Rituximab you give for 4 at 8 doses. You hope that all the lymph nodes will go away and that the disease doesn't come back. So the anti-IL-6 antibodies are lifelong therapy. Then rituximab is perceived as a single course treatment. But in reality, we don't know too much about how effective the rituximab therapy is. Because usually people have combined it with chemotherapy. So there are very limited data about the use of rituximab on its own in multicenter Castleman's disease. Nevertheless, it's not unreasonable to try in some patients. Now, the people who are severely ill, again, the first line treatment is an anti-IL-6 antibody. But these patients, they can deteriorate very quickly, and they're really at risk of dying. So there you've got a big conundrum. You've got somebody very, very sick, in danger of literally of losing their life, and they're in intensive care, and they've got a benign disorder. And there's great reluctance among doctors to give these patients chemotherapy. Why give chemotherapy to somebody who doesn't have cancer and is severely ill in intensive care? And it doesn't make sense for not doing it. And what happens? The patient dies. So that is a really difficult decision to do that. Having said that, when you give the chemotherapy, some patients give it better remarkably quickly. So sometimes it's the only way out. But it's truly a very difficult decision. So what can you expect with Castleman's disease? Well, before we started the CDCN, I think there was a lot of bad information out there on the internet. It's very frightening to read that you're only going to live for a couple of years. I think in general terms, you're going to have a good outcome. So what can you do after receiving a Castleman's disease diagnosis? I think the most important thing you can do is to get yourself to a doctor who knows something about Castleman's disease. It's completely unfair to expect your local doctor to know something about Castleman's disease. This is a rare disease. He may only see one patient or two patients in his whole career. You cannot be an expert in a disease that you do not see. So it's very good to be seen by somebody who has experience with disease, and he can work with your local oncologist to guide the therapy. And I think that's important in terms of improving outcome. So the historical outcome of multicenter Castleman's disease is that there's a 5-year survival is in the order of 65%. And this afternoon we'll have Dr. Oxenendler from Paris here, who's one of the world's experts on Castleman's disease. He recently published his data, and his data are much better than this. So it does make a difference where you're being treated. These are data from about 63 patients treated at our center, and the overall outcome is better than if you're treated at random in the community. So get yourself in contact with the CDCN, as you've already done, and get seen by a doctor who's got experience with this disease. And again, get educated and learn about disease, learn what subtype you have. This is a very heterogeneous disorder. Patient advocacy is incredibly important. You can learn about disease, you can get educated, you can find your way to an expert with Castleman's disease. You can learn what to look for. What are the things that I need to monitor in my lab work? You need to be able to understand some of your basic lab work. And it's also important to establish what actually are your treatment goals. How is this going to work? What is eventually going to happen? And I think a very important aspect is also the psychological support, both from the CDCN and locally, with your family or other therapist or other persons. I'll talk about that a little bit later more, but to have a chronic disease has a major impact on the way you function and the way you perceive life. So it's a very important event to be diagnosed with Castleman's disease. So what about these labs? So the Castleman's disease produces these cytokines, interleukin-6, VEGF, and others, which we're currently discovering. One of the major players is the liver. The liver makes something called fibrinogen. Fibrinogen is a clotting factor. If you have too much fibrinogen, you can get blood clots. Fibrinogen also gets stuck to red cells. And if you put red cells in a test tube and you let them settle for an hour, you can measure how quickly they settle. This is called the red cell sedimentation rate, set rate, or ESR. So this is an indirect measurement of the effect the cytokines have on your liver. The liver also makes albumin, and these cytokines can switch off production of albumin by the liver. And again, you have less albumin in your bloodstream, and the fluid leaks out in your tissues, and you can get this massive fluid accumulation. Also, you can have an effect on the way you use iron. Although you have enough iron stores, you're unable to utilize them, and you become anemic. And there's something called C-reactive protein, which is being produced by the liver. And these cytokines induce the liver to make CRP. And this is a measurement of this inflammatory syndrome. If you have a severe flu, you'll have nitrous fevers, you will be very unwell, and your CRP will be high. The other thing is that CRP correlates quite well with interleukin-6 levels. So it's a good readout of how much interleukin-6 you've got floating around. So these are the key laboratory markers to follow. And it's worthwhile to be aware of them. Now, we're not keen on following interleukin-6 serially for two reasons. Once it's been shown that the level of IL-6 does not correlate very well with symptoms, and that probably has to do with the way IL-6 has been measured. The interleukin assays vary, and they're not that reproducible. Secondly, once you've had an anti-interleukin-6 drug, like the cetuximab or the tocilizumab, the Actemra drug, the IL-6 levels will be falsely elevated for 12 to 18 months. So sometimes patients get this cetuximab drug and they say, oh, my IL-6 levels through the roof. And we even had, David told me a story about a doctor who wanted to consider doing a stem cell transplant on a patient who was otherwise doing perfectly okay, but just the IL-6 levels were high, and they were falsely high due to cetuximab administration. Now, how often do you want to measure these? In the beginning, when you're getting active therapy, the answer is frequently. Weekly, every other week, sometimes more frequently. But during prolonged therapy, and once you're doing well, maybe every month or every 2 or 3 months, the intervals can be spaced out. Okay, now why are these laboratory markers so important? Now, first of all, it tells you something objectively about the disease activity and the disease severity. Secondly, you can use them to assess the response to therapy. So these laboratory markers should normalize when you get treatment. And finally, I will show you in a moment, it may help you also to select therapy. So what do all these patients share here who are so severely ill? They're very anemic, they will have sky-high CRPs and sedimentation rates. They will have abnormal renal function. So these, again, it's a measurement of severity of the disease. So these are data from the randomized cetuximab trial, in which one group of patients got a fake drug and the other ones got the cetuximab. And the fake drug patients are here in the red line and the cetuximab in the blue line. And here you can see that the CRP comes down very nicely. The hemoglobin goes up in the cetuximab arm. And with the fake drug, there is no improvement. Here you can see the fibrinogen comes down with cetuximab and the sedimentation rate goes down. In other words, the change in laboratory markers reflect response therapy. Now, we've recently published a paper showing that these laboratory markers can also help to predict response to therapy. Patients who respond to cetuximab will have a higher fibrinogen level, a higher CRP, a higher hemoglobin levels, and we build a model to see whether we can predict, based on the laboratory markers, who's going to respond to cetuximab or not. And although the model is not perfect, it's in the order of 85% prediction that will correct. So these lab markers are important in selecting therapy as well. So the other thing which is very important is to learn how to interpret laboratory markers. And that takes a little time to get a hang of it. First of all, no single test will tell you the whole story. You really need to look at all of them, and you need to look at them in context. Secondly, serial measurements are much better than one measurement. And sometimes one particular marker is better for a given patient than other markers. So other diseases can cause these laboratory markers to be abnormal as well. For instance, a prolactin can be abnormal for many reasons: hypertension, diabetes. Again, if you've got a flu or a cold, your CRP will go up. There are many reasons why these things can go abnormal. So it's not just the Castleman's disease. Then different laboratories may use different reporting ranges. So somebody tells me that they've got a CRP of 100, and on our laboratory scale, that CRP would be 10. So it's be very, you have to be very careful in comparing labs between different laboratories. It's also one of the reasons that you should be careful comparing your results with somebody else's results, because they may not necessarily give quite the same information. And again, serial tests are much more important than one test. And it's sort of important to see the whole picture and everything in context together with your symptoms and your lymph nodes. These are the key symptoms that you want to be able to keep track of. And I think we've already alluded them sufficiently. Now, what about side effects? Steroids. Again, steroids will work, but unfortunately steroids have side effects. Weight gain, some people get fat deposition in their face, we call it moon face. You can be irritable if you get steroids. You can get a high blood sugar, ankle swelling, stomach upset. So that's one of the reasons why high-dose steroids are not feasible to give long-term. So to give intermittently steroids is possible. And they're very strict, once weekly, sometimes people do it every other day. There are various ways how steroids can be given to minimize side effects. And rituximab. Rituximab is very well tolerated. Like any antibody, you can get an infusion reaction with the first dose, fevers, chills. Many patients do not. It will knock out some of your normal immune cells. These are called B lymphocytes, and they're important in making antibodies. So if you get chronically rituximab, your antibody levels will be low, and you will have an increased risk of getting infections, both viral and bacterial. One of the ways you can deal with that is giving an antibody preparation. It's called IVIG. It's expensive, but you can have it once a month. And it can replenish your normal antibody levels and reduce the risk of infections. Usually it's given to people who've had multiple infections, who seem to be having more prone to get infections due to low antibody levels. Then the siltuximab, tocilizumab now has been extensively used. We've done what is called an extension study, where people continue to have siltuximab on a clinical trial. There were 19 patients. One of my patients have had siltuximab since 2005. That's at 200 doses. So in general terms, it's very well tolerated. So the main side effects are elevated cholesterol. You need to have your lipids checked. Some people will run a somewhat lower platelet count, 200 to 150,000, which is perfectly okay. And usually we don't see any strange or weird infections. Occasionally there might be mild abnormal liver function. Again, the tocilizumab drug does the same thing, and they appear to be equally effective. They've never been compared head to head, but and they probably will never be. But I think that there's not much difference in one, there's side effect profile, and secondly, their efficacy. Okay, chemotherapy, and here we're talking about combination chemotherapy, multiple chemotherapeutic drugs, like giving for lymphoma or for giving for myeloma. And they've got the traditional side effects. You'll go through a period that your blood counts are low, you're open to infections, you may be anemic, have low platelets. There can be some side effect, malaise, lack of energy, nausea, diarrhea, sometimes loss of hair. So this is what I call the real chemotherapy, and you're also more susceptible to infection. So the prophylaxis here and the management of symptoms with chemotherapy is very important. You've got a whole array of novel drugs which are very good at preventing nausea and vomiting. It's very important to have an active discussion with your physician assistant, nurse practitioner or doctor, and inform them about the trouble you have. Because sometimes with the next cycle you can prevent a lot of the things. Again, it's a major life event to be diagnosed with Castleman's disease. And coming to terms with this and dealing with this can be very difficult. So ideally we want to wind up in a stress-free zone, but that's not always possible. So there are major adjustments which take place. I mean, there are issues with work. I mean, will I ever get to normal? Can I look after my family? You know, people have sometimes sleep disturbance. And sometimes they just don't function. They don't seem to be be able to get going. So there are a number of things that you can do. There's no magic diet that cures your Castleman's disease, but to follow a regular routine, eat a healthy diet, do some exercise, all of these things help. I always suggest some alternative therapy which can help biofeedback, relaxation, help to alleviate stress, and talking to people, whoever you trust in, a family member, a pastor, counselor, it can really help. And sometimes just connecting with other patients helps. Because hey, I'm not alone, other people have this too. How do they cope with that? So there's an important psychosocial aspect to the disease. A couple of quick things to finish up with. Some people worry that once they have unicentric disease that you're going to transform into a multicentric disease. It just doesn't happen. We have not seen that. Vice versa, if you have multicentric disease in remission, you're unlikely to develop unicentric disease. So you stay within one disease. Unicentric disease very regularly can transform to a cancer, a rare cancer called follicular dendritic cell sarcoma. And the experts disagree whether unicentric disease can sometimes go into a form of lymphoma. I think it does, and others in our scientific committee don't think it does. But in general, UCD will have a very good outcome. Then there's the issue of pregnancy. I think the first thing to realize is that if you do get pregnant, or you want to get pregnant, that you get a fertility expert involved. A healthy mother will produce a healthy baby. That's that's the way nature tends to work, not always. So treating the disease helps during pregnancy. Also, pregnancy is a very immunosuppressive state, because you have a woman has a foreign, literally a foreign living creature in their belly. So the immune system is suppressed. This is one of the reasons why pregnant women get so severely ill with influenza. You read that in the newspaper every now and then. Certainly, probably the effect of the anti-IL-6 drugs on sperm will wear off. There are no good data that the anti-IL-6 drugs cause trouble in animals, but I think it requires a very careful discussion before you get pregnant. And again, a fertility expert is important. So my last message is really don't be afraid of looking forward. For most people, the future is bright, and you will be able eventually to return to your normal life. And again, gets involved in advocacy. Be your own advocate, be your own warrior. Be in charge of your disease. To be informed, to be knowledgeable is very important. So be proactive, and I think all of you are already proactive because you are here. But I think that's a very important aspect of any chronic disease. And I will take some questions here. We don't have patient surveys.
Probably a couple minutes for questions, and there'll be a question and answer session this afternoon. It'll be an hour long.
Chemotherapy kind of shocked my body back to normal. Is that true?
Well, without knowing mean, your specific details, I don't know. The question is, he's not responding to siltuximab, and he may need chemotherapy. Yes, that may be the case in some patients. Other patients we may try rituximab first. There's also the sirolimus drug that we're not trying. So it really depends on the individual patient. So that there's not a standard answer. To answer your answer specifically, yes, it's possible you may need chemo, but you may not.
I think one comment I'd add to that is return resistance. I think that if you're not responding, it's probably not that you have a quote-unquote resistance, like your body's rejecting the drug in some way. It's just that the drug doesn't work for everyone. It works for some, it doesn't work for everyone. If it's not working, that doesn't mean that your body is doing anything to the drug. It may just mean that the drug's not the right thing.
So, in terms of the anti-IL-6 antibodies, I think they don't work for people who've got very few symptoms and very few abnormal laboratory markers. So that's one group who doesn't work. But then there's the other group who are more severely ill, and they either just too ill for the siltuximab to have time to work, or particularly with the TAFRO patients, there's probably at least half of them where IL-6 is not the driver of the disease. So there are different reasons why you might not respond to siltuximab. You know, very minimal cytokine storm, elevation of cytokines, or just being very severely ill, or the IL-6 is just not important in causing the Castleman's disease.
So if it's working right now, then it will keep working. It won't later on, like years down the road, it won't work. If he's responding now, he'll continue.
Okay, usually people who respond will continue to respond for the majority of patients, with some exceptions.
I have a question about CD while being pregnant. If your body starts to attack your baby, in what ways does that happen? Like, it's just too broad of a spectrum. Like, I got very, very sick when I was pregnant, and my son came out with a few very minor deformities, but we weren't able to figure out what they were from, and this was before I was diagnosed. And I'm just wondering if it had anything to do with my CD, if that had caused him, if me being sick, if my body was attacking him, just in case I did want to get pregnant again, like how I would go about that.
So, in general terms, if you're sick, whatever is causing the illness, your body is not able to support properly a developing child. So, as a rule of thumb in medicine, you want to get the mother as healthy as possible with treatment in order to develop the normal development of the child. Drugs are most dangerous in terms of causing deformities and other abnormalities in the first trimester, in the first 12 weeks. Because more or less in the first 12 weeks all the organs are formed, and to put it simplistically, afterwards everything just gets bigger. That's not quite true, but that's sort of the way it works.
What's the, for people who receive rituximab, you said they're more susceptible to infections or sickness. Is there a general window on when you can be less worried?
Well, once you get less rituximab, your immune cells may recover and you will start producing better antibodies. But if you get rituximab once a month as a maintenance strategy, usually the immune cells will stay low and you won't be making proper antibodies. Does that answer your question?
So, yes, I understand. So is there a general, like you just do a series of 4 doses? Is there like a safe time?
Okay, so you would expect that your antibodies will start to come back to normal by 6 to 9 months with a single course of rituximab. However, that is variable. There are people who recover much quicker, and there are people who take longer. And again, the more rituximab you get, the slower these recoveries are going to be.
Is it worth taking rituximab as a preventative if my symptoms are very mild. Is it worth taking as a preventative, or is it just better just to leave things as they are and just let the mild symptoms go and see how we go? Or
Okay, so in a multicentric disease, there is some chance of it transforming to lymphoma. And we don't know how high that chance is. It's probably low, but hopefully the natural registry study that we're conducting will answer that. It's classically said to be 10%, but where that number comes from, I really don't know. It's probably less. So if you have a younger patient, which you are, and you to walk around for 20 years with mild symptomatology and diffuse lymphadenopathy, I would be a little uncomfortable with that. Now, I will tell you that some of my colleagues will tell you just to observe and not do anything. So there is some different opinions about that. I think Dr. Oxenhandler, who will speak this afternoon, is probably of the opinion that you want to observe. I'm probably a little bit more aggressive and will give you treatment.
I think we have time for one more question, and then there'll be a nice question and answer session this afternoon.
Yeah.
So just since it's about like 10 years, and you still have your spleen alarm, does that mean it's not working, or should you try something else?
So the question is, she's on siltuximab, and after 1 year the liver and spleen are still enlarged, and is the drug working? So it depends on how you present. If you have enlarged lymph nodes and they're getting better, if they, sorry?
More lymph nodes.
You have more lymph nodes, and what about symptoms?
Mild.
Yeah. I suspect that from hearing that probably the siltuximab is not working. If your symptoms are more or less the same, and you still have lymph nodes, by 1 year your lymph nodes should be smaller on siltuximab. You may belong to people who are more on this milder spectrum, but not a marked inflammatory response, for whom siltuximab is not the right drug.
Because I did try rituximab.
Yeah.
And I had like this that my body wasn't tolerating it.
Okay. Some patients with all the antibodies, you can get infusion reactions. Sometimes these infusion reactions are severe, and the oncology doctors don't want to give it again. Now, you can desensitize patients to the rituximab. If you had a bad reaction first time, it can be given again, but you need to have a desensitization protocol. And it's usually given over 24 hours in hospital, and there's a way of doing that. And it works very well. I've done it for several antibodies. So it doesn't preclude you ever having to rituximab again. But you do need to go to somebody who knows how to desensitize you.
Thank you so much, Dr.
Okay.
It's always